Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back for another episode of 8 Minute Rule. We got all the fellas here together today, and we're going to start off with the icebreaker. This one's all play to win here. So we'll start with Drew first because he's on my screen to the left. If you were not a physical therapist, what would you be?
Oh, gosh. That's hard. Wouldn't want to be anything else.
Oh.
I would maybe be jobless and homeless, but just drive around and bike.
There you go. Biking everywhere. Lucas, what would you be if not a PT?
Engineer.
Engineer. I like it. Mark.
I like the engineer answer, but I'd probably be something more like a CPA or something.
CPA.
I'd say he'd be a pro kicker, probably.
If only.
Yeah,
I
there
get
may have been some
another guy.
limiting factors to that, but
Fair enough.
it's a conversation for a different time.
Very
Yeah.
cool. I would be an anthropologist, actually, believe it or not. Love digging and finding fossils. Good stuff.
Indiana Jones, huh?
Well, yeah, that would
Indiana Jones.
might be dating ourselves here, guys, and a lot of people on this podcast listening to this may not know what that is. So, all right, today what we want to discuss is essentially post-op protocols and the process of dealing with the post-op patient. Kind of looking more generalities here than anything else. So, we got a lot of different viewpoints on this podcast that we get to listen to. So, where I want to start with is for Lucas. What would you tell yourself as new grad, Lucas, that you, at least one thing that you would really love to share with yourself as a new grad about post-op patients and treating them?
That post-op is just a guide to give you the safety that you need in order to do what you need to do and to use your best judgment.
All right, so using it as a guide, using it as your best judgment.
Yep.
Drew, what about you? What would you tell a younger Drew about treating post-op patients?
I think the biggest thing would be that they're trying to base a lot of these on tissue healing times, and you can use that, but also recognize there's so many other lifestyle factors that are going to play a role into it. And so the tissue healing time for one person is going to be different than another, especially if they have a lot of unhealthy behaviors. So just because somebody may not be meeting that immediately as it looks like on the protocol, you don't have to freak out. And you can also try to help coach them along in their making better, healthy decisions so that they can recover faster.
I love that direction. One of the things I've always thought in terms of our field is that it's an opportunity. Somebody comes in for their back pain, and we actually get to address potential lifestyle change. And kind of to your point, we've got somebody had an operation. Maybe it was elective, maybe it was not, depending on what happened here, but they had an operation, and now they've got likely some motivation that they want to get back to something. So you should have a pretty good goal in mind. And you've got a golden opportunity here that, hey, can we discuss some basic parameters of movement? Can we discuss maybe some basic nutrition changes? Because we know if you eat well, if you're not smoking, if you're getting sleep, I mean, that's going to increase your healing time, right? I mean, so I think some really, really cool opportunities there. Love it. Mark, you're the youngest of us, but, graduated, what, 2 years ago? What would you tell yourself as a new grad?
Yeah, anyway. Echo the sentiments thus far. The theme that I've kind of seen is that protocols are designed as a one size fits all. It's kind of a safety net for everything. However, we know that rehab is not a one size fits all. And so, like, I'll give you an example at the tail end of like an ACL protocol. It's like, oh, 9 months, return to sport. Well, they just because the protocol says that does not mean that they are ready. In a similar way, if someone has a hip replacement and the protocol says, oh, at 6 months they can do blank, but they're not ready for that activity, that's not a green light for them to just go and do that thing.
Yeah, big fan of that. And so we need to use our common sense. We need to be able to recognize we're clinicians. I think early on, I had one of my mentors that told me protocol essentially is your guideline for this is where you're not really supposed to push past. You can pull back. I think sometimes we don't like that because we want to be ahead of the curve, but really the protocols we're looking at the physician again, assuming, and you don't want to assume. You don't want to assume that all protocols are right. I've gotten plenty of surgeries. I think I got a labral repair, a shoulder labral repair, probably 3 months ago, and the protocol was written for maybe 10 years prior. And so called up the doc and he said, yeah, there's 3 things on there that weren't right. Now, hopefully most physicians are keeping things up to date, but I think it's good to communicate and make sure that you've got a good line on there. But
I like to
uh,
tell my students and residents and everybody that asks, like, at the end of the day, the surgeon was there. The surgeon was inside. He knows the quality of that tissue, right? He knows how well the graft was attached. He knows how well the tendon, the tissue, whatever it is that he's anchoring is, right? And at the end of the day, after he finished it all up, he brought that joint into a full range of motion, assessing. So he knows more, way more than what's written in any protocol, even if the physician actually reviewed that recently. So communication with the physician is like, hey, doc, I need to know that so I can give the best shot to your patient and make you actually look better than you would think you would. But at the end of the day, that's communication.
Yeah, and communication is key there. And to play the flip side of what Lucas's point was there is that the surgeon knows the surgery, and we as PTs should know the rehab. That is our area of expertise. We should be proficient at progression of forces, so that when we are communicating with the surgeon, then we can have a very clear conversation where it's, hey, they are able to do this activity now, without any limitations or any issues. Are you okay with me progressing to the next thing? And I think that communication is where what's so important.
I think that's a great point. Sometimes you can get a protocol that's about 8 pages long, and it's got literally day one quad set active range and it's literally spelling out every detail as if I could hand it to my mom and she could be able to run a patient through that. And then other times you get protocols that literally just have one range of motion on the first 3 months. And so I think to your point, we need to realize this is a spot for us to jump into. We're seen as experts. I've talked to several surgeons that are like, I'm not going to tell you what exercises to do. That's y'all's job. That's your specialty. And so we want to own that. We want to be able to make sure in our communications, like you're talking about with the physician, that we're assuming that step of, yeah, we do understand, and not arrogantly, but confidently, in knowing that this is our part. If literally it was just going to be a complete protocol where everything is laid out, they won't need us. Like I don't need to be there to run them through something that's exactly right. So we want to be able to step into that space, take a golden opportunity to chat with physicians around. Not everybody's going to have them right across the hall like Mark does, which is a great opportunity. But just kind of thinking on the other end of the spectrum, Drew, what are some things that you have seen in terms of this as an opportunity communicating with surgeons post-op? Have you had some good experiences on that, or some things that you can share that you think are helpful?
Yeah, I will say my post-op caseload is not incredibly high, but whenever I do have some of the post-ops, I try to use it as an opportunity to communicate with the surgeon and develop that relationship as much as I can. Um, if anything does deviate, like that's usually one of the first places that I'm going to go to and let them know, hey, this patient is either progressing really quickly or they're struggling because I don't want the patient necessarily to go back and the surgeon to be surprised by where the patient is at. So I'm going to use those opportunities, one, to create the relationship and let the surgeon know directly from me rather than hearing who knows what from the patient. Um, and I had another thought in there. Oh, so one of the other things that I think it was when Mark was talking, I just maybe it's a random thought, but as we're going through some of those protocols of like it has this exercise, this exercise. Um, I know early on in when I started, so kind of back to that again, is I would kind of look at that and be like, okay, just do this and focus on whatever body part that was, instead of even stepping back and looking up and down the chain. What are some of the things that you could that maybe contributed to this previously? So like, don't get so focused in on one area that you miss a bigger picture, things that you can start working on. Before they get to the point where they can start running and jumping. And then they're going to be ready to go instead of, ooh, they start moving and you're like, oh, that doesn't look good. And then you have to wait a little bit longer. So I don't know if that really answered your question, but that's multiple thoughts all at once.
I want to circle back what you're saying with what Mark said earlier, that physical therapist is what who knows what to do. And there is a thing that it goes unused or underutilized, or people just don't pay attention. I had a resident not long ago telling me that pissed off that the surgeon asked her to do only passive active assisted range of motion. She looked at me like, what am I going to do with this? Like, just passive active assist for like 10 minutes, 15 minutes. If you want to know how long it takes to work on a shoulder that is super guarded, and how much you need to do with that passive, and how much you can add and help the patient with that passive range of motion, soft tissue, periscapular soft tissue, patellar soft tissue, whatever it is, you need to review your education and training, because yes, to Mark's point, we need to know what to do.
Last thought, because I know we're running on time here, but make sure as PTs that we are not neglecting the uninvolved side. To Drew's point, looking at, you've got the protocol that you can do on the involved side, but the uninvolved side definitely needs love, and they need to be educated on how to maintain and everything on that side while we are focusing on their surgical limb.
Yeah, golden point. I mean, people, you come in with shoulder surgery and they're depressed because they're not moving. They want to move, and they're not even walking. Like, there's nothing wrong with your legs. Like, make them sweat. I mean, have them doing a bunch of freaking leg raises with the weights if you want to. I don't care, dude.
Yeah.
Have them on the sled. I think there's a lot of stuff that you can do, right? And we know that people that sweat, people that get moving, they're going to heal better. They're going to have a better mentality as they're going to settle in. And I think that kind of goes to kind of the last one point I'm going to finish with is never forget patient expectation, right? So your first session, as you said, Lucas, you got some patients that come in and it's just passive range of motion for a couple weeks. That's the main thing that you could do. Great opportunity to spend a lot of time in that first visit with education. What means something to, what do they want to be able to do? What can I use my brain to still get them moving in the clinic that doesn't involve that surgical spot that we can work with? And I think they're going to enjoy it, and they're going to have more fun in doing so, and you get to move in the right direction. We know it's all helpful. So good stuff. Appreciate the input, fellas. I hope everybody learned a little bit, and I look forward to talking to you guys again next week. Have an awesome week.